Well, good evening, everybody. I'm Therese Steyer, AARP statewide advocacy volunteer. On the 16th of August, President Biden signed the Inflation Reduction Act. This bill includes key AARP priorities that will go a long way to lower drug prices and out-of-pocket costs. For our coffee shop talk tonight, my co-host and I, Ernestine Jackson, a Central Ohio volunteer lead and executive council member, want to thank you for participating in our continuing conversation about what has been happening to reduce the cost of prescription drugs on the national and on the state levels. On the national level, AARP has called for lower drug prices for years and strongly supported the Inflation Reduction Act. Millions of American seniors will see lower drug prices as a result of this historic legislation, which requires Medicare to start negotiating the price of certain drugs, penalizes drug companies that increase prices faster than inflation, caps seniors' annual out-of-pocket costs for prescription drugs on Medicare Part D, limits cost sharing for insulin in Medicare drug plans, and extends financial assistance to help people afford health insurance. AARP has also been hard at work at the state level, pushing lawmakers to advance legislation that will help reduce prescription drug prices. The last time we were together talking about prescription drug prices, we spoke with Representative Beth Liston and Director Leigh Purvis. Representative and Dr. Beth Liston is serving her second term in the Ohio House, representing Dublin, Worthington, and Northwest Franklin County. Director Leigh Purvis is from the AARP Policy Institute, where she heads the work on prescription drugs and mental health issues. Leigh provided federal insights and information about the high cost of prescription drugs and the impact to all of us and what was happening on the federal level to reduce those costs. Representative Liston provided us information about state legislation she's sponsoring that will have a life-saving impact for those who take insulin. Tonight, we're going to revisit the federal and state legislation efforts, get some updates, let you know how you can join the fight. And really, we've got a lot to unpack here because so much has happened. And Representative Liston and Director Purvis, we're really lucky and privileged to have you join us again. Before we get started, I'm just going to ask you guys if you have questions to put those in the chat box, and we'll get to as many as possible during the Q&A portion of the event. But Ernestine, I'm going to turn it over to you because we do have a lot to talk about in this critical discussion.
Yes, we do. So first, let me start by saying thank you for joining us, Leigh Purvis and Beth Liston. We are really excited about this discussion. I think that there are a lot of people who need a recap and a better understanding of what in fact has happened recently. So let's just jump right into it. And I'd like to start with you, Leigh, if you don't mind, kind of give us a recap of the recent legislation as it relates to healthcare and specifically lowering prescription drug prices. Sorry about that. Okay.
Absolutely. And thank you again for having me. I really enjoy these conversations. Wow, where to start on what's happened at the federal level. So this has been a very long debate about what should be done about high prescription drug prices. And I think the culmination of that was the Inflation Reduction Act, which, as you've already heard, contains a lot of provisions that are incredibly helpful for older Americans. You heard about secretarial negotiation, which is allowing Medicare to negotiate prescription drug prices for the first time. You heard about the out-of-pocket cap under Medicare Part D, which will be $2,000 starting in 2025. There are also going to be strong penalties for drug companies that increase their prices faster than inflation. And then those insulin copay caps where people won't have to pay more than $35 for their insulin. And those are the things that people have really heard a lot about so far, but there's actually a lot more in there that's incredibly helpful for older Americans. For example, not nearly as many people are aware of the fact that most vaccines will now be free under Medicare. And there are shots, for example, for shingles that used to cost people upwards well over $100. That will go away. So vaccines will now be free. The other thing I think is really important is that Medicare Part D premiums will not be able to grow faster than a certain amount for the next several years. So that can present some savings for people who potentially were looking at high premium increases over the next few years. And then another really kind of cool thing is that people in Medicare Part D who are facing those high out-of-pocket costs will be able to spread them out over the entire year. There were people who were having to pay thousands of dollars in January, and that will no longer be something that people have to worry about because of the option of spreading those costs out over the entire year. So there's some really big changes in there that affect everyone. But I think it's really important to keep in mind, this is a really big historic change for everyone.
Wow, that's great. I mean, that's a lot of information quickly. So just to keep it moving, Representative Liston, would you share with us at least what's happening at the state level?
Yeah, absolutely. And thanks for having me. I too enjoy talking, and I'm happy to also learn from Leigh and all of you. So the state level, honestly, currently is relatively quiet because we are on break and have not been in session for a couple of months. However, I too am very passionate about making sure that we address some of the issues we've discussed, including making sure everyone has access to prescription drugs at a reasonable cost and an affordable price. So I have focused for a number of years and hope to mirror some of the federal policies, taking a look at the insulin costs. I think everyone's probably aware of how expensive it's been, how the prices have increased over the last number of years, despite the fact that it's been around for, over 100 years. Unfortunately, although it's changed for Medicare at the federal level, it does leave still a number of people that are unable to afford their insulin. Ohio, myself as someone who's introduced this bill, we've introduced a number of times the same concept, that legislation to limit the out-of-pocket costs per prescription for insulin per month to $35. And I have a bill, House Bill 305, that is bipartisan with Representative Manning, and also has a companion bill in the Senate with Senators Herschel Craig and Nathan Manning. So we have a bipartisan, bicameral bill to do this. And this would impact people under 65, the group of individuals that do suffer from diabetes, but kind of fall in that gap where they may not have Medicaid, they don't have Medicare, but still may have high out-of-pocket costs and co-pays. So we have a bill to do that.
Representative, real quick, do you think that this legislation federally may help, the cause for pushing your legislation? Like, now that this has happened, will it give you some traction, do you think?
So I think, yes, I do. So, just to say where things stand, the bills have been introduced. We've had a couple of hearings, but they really haven't moved quickly through the process. In fact, it's been very slow. We introduced them at the very beginning of the General Assembly about 18 months ago now. I do think that the traction overall for just addressing insulin costs has been building over the last 3 years. I know that there are 23 states and DC that have done a statewide copay cap. When I first introduced the bill a number of years ago, it was just Colorado. Colorado was was the first, or certainly one of the first couple that enacted a copay cap, and we've seen that spread and grow. And I think the conversation changes as people hear it and are comfortable and familiar with both the idea of capping the copay, as well as have a good understanding of just how expensive it is and how harmful it is for people not to have insulin. The momentum increases. And I think that happens at the State House, where in Ohio, you talk about something, people hear it, and the first time they hear it, they're like, I want to learn a little bit more. I don't really think that's happening. And ultimately, it changes culture if you keep talking about it. I think that the culture is changing. Absolutely, everyone understands the issue. And now it's becoming so widespread that this is a sensible solution. I do think that the federal legislation will help people to see it as, oh, well, yeah, of course we should do that. Everyone's doing that. All the states are doing it. The federal, Medicare is doing it. We don't want Ohio to have, people in Ohio to be suffering more than they need to when other states are finding this solution. So that was a long answer, but yes, I'm hopeful. I think the conversation has changed, and hopefully we can use some of that momentum to keep moving forward.
So before we get further in, are there things that we can do as citizens, as advocates?
Yeah.
At
Here we
this
are.
particular point, and for each of you, talk about that a little bit. I'll start with you, Representative Liston, because I hear what you're saying. You're kind of at a stall point.
Yeah, we're at a stall point. We've been at a stall point for a while, but I think that, again, there's still been awareness, and we keep talking about it. And I think we're at a point where everyone sees the problem and understands that it's a problem, and that, is something. We're also at a funny point in the cycle. We have 2-year,
yes,
2-year cycles, right? There are new representatives that come in every 2 years. And we only have probably about 6 weeks where we'll be back in session for bills to move forward. So I think that the likelihood of this bill passing in this General Assembly is relatively low, simply because of timing, right? Bills have to have a number of hearings. They have to have proponents, people for it, people against it, and conversations about the bills in a committee. Then they have to pass a committee. Then they have to pass the floor, which is, the entire body. And then they have to go to the other side and do the same thing. And that process is not rapid in many cases.
Yeah.
Ever.
Right.
Well, it can be. I mean, if there is a, broad, huge support, it can be a little faster. So I think what we need to do is continue to raise the awareness and increase the conversation around insulin. I think that if you want to be concrete, specific right now for the bill, House Bill 305, then it is currently in Health Committee. So the chair of Health and the vice chair of Health are people that anyone can reach out to, send an email, give a call, and say, hey, this bill is important to me. It's important to people in Ohio. Here's why. Please have additional hearings on the bill. As I said, I think that it may not happen during this General Assembly, but the conversation is important, because it ultimately becomes, well, yeah, of course we should do that. And certainly the federal changes, can bring that forward too.
Yeah. Do you think maybe at this point we should see if there are questions from our audience that we can't see? And if not, then I want to come back and talk about resources.
Yeah, I don't have any questions in there this minute.
Okay, so let's talk a little bit, excuse me, about resources that are available right now. Some of the people that I've spoken with are concerned that the federal legislation isn't going to kick in right away. So they're like, what can I do? Or, where can I go? Or, etc. So you want to talk about that a little bit, Leigh, please?
Sure. And this is advice that I give out pretty regularly, because unfortunately high drug prices have been a part of our lives for so long at this point. But the first thing that I always recommend to people is talking to their healthcare provider. A lot of times people are taking a really expensive drug and there might be a less expensive alternative. So that's always the first place to start. Something else that you can look into is, for example, under Medicare Part D, there's something known as extra help, and that can provide a lot of assistance with your cost sharing and your premiums if you qualify. And then another option that a lot of people don't necessarily think about is the drug companies themselves. A lot of them have patient assistance programs. And so if you can meet their eligibility criteria, you can actually get access to your drugs for a greatly reduced cost or even for free. So that's one way to kind of keep your costs down as you're waiting for all of these big changes to start kicking in.
That's a really interesting point. I'm sorry, Teresa, I didn't mean to cut you off.
No, that's okay. I was just going to say this works out so perfect. There is a question, Ernestine, and I think it works right with what you're saying, Leigh. She says, as a type 2 diabetic, I don't take insulin, but have to take some very expensive drugs nonetheless. Will there be relief for these drugs too? And I think you're answering that for her.
Yeah.
Yes, and those are the types of drugs that are going to be targeted by what's coming. So that negotiation and those penalties for price increases, because those are the types of drugs that are going to qualify for negotiation. And those are unfortunately the types of drugs that have been seeing those big price increases. So those provisions are going to start bringing some relief to people who are on non-insulin drugs. And that really is, frankly, a lot of people. And so that's what we're hoping and expecting to see from this legislation, is everybody seeing some level of price relief in the future.
Yeah. A lot of, excuse me, a lot of emphasis has been put on Medicare. Is there help for people who are, for example, on Medicaid or other kinds of support?
Yeah, and that is a complicated question because it varies by the type of coverage that you have.
Yeah.
But a lot of what we're seeing in terms of what people are talking about or what's in this bill have impacts that are broader than perhaps they look at first glance. So for example, the inflation-based penalties, those penalties for prices that increase faster than inflation, they're technically, the actual penalty will be based on rebate sales. But what the data they look at to determine whether a price increase took place is based on a price that applies to a much broader population. So the expectation is that will help reduce those big price increases outside of the Medicare program. So just because everything is so incredibly complicated and connected, it's important to keep in mind that a lot of what you're seeing is actually much bigger than it might appear when you first take a look at it.
Okay, that's good. I think that's helpful. Yeah. I'm
Do
sorry.
you think, Representative Liston, will your legislation, because it covers people who have, health insurance, right? Will that help fill some of this gap that we're talking about with these medications? So we've got, people who are on Medicaid, they have some help, and now Medicare recipients will get help. Is that a benefit to your legislation, that it'll kind of form a package around this whole thing?
Absolutely. That's the intention. There's Medicare is now going to be affordable, hopefully, or at least more affordable. Medicaid insulin is free, and truthfully, they have a lot of ability to manage drug prices within that program. But it's kind of the people caught in the middle that have, the health insurance is on the exchanges or, through other means. It doesn't, unfortunately, get people that have health insurance through self-insured companies. So if there's a big, say Ohio State as an example, Ohio State insures all of its employees, has its own insurance company that's still federally regulated. So unfortunately, the most of what I can do in the state level is, somewhere between 25 and a third of people with health insurance that the state legislation can impact. And obviously the one bill that we've talked about, 305, is specific to insulin. But I do have another bill that I think is somewhat relevant, in that it's House Bill 153, which prohibits non-medical switching. So someone had asked about non-insulin medications, and I think one of and this is a little bit of sideways of it, but I think one of the experiences many people sometimes have is that they may get on a regimen of a medication that they've worked with their doctor or provider on, and they know how much it costs and can afford it. And then the insurance company changes whether it's a tier 1 drug or a tier 3 drug. And all of a sudden people have to pay a ton of money unexpectedly when they go to fill their prescription. So we have a bill that prohibits insurance companies from changing the price in the middle of the plan year, changing the coverage for it. So, hopefully if people are able to work with their providers and able to have medications that they can afford, that there's not a bait and switch kind of process where the medication all of a sudden changes. So I think those are two places that at the state level we're working, and I don't actually know if there's anything federally that looks at that sort of the plan switches and the non-medical switching that I think can take people by surprise. But certainly that's one of the places.
Is it, Leigh? Do you know?
I haven't heard anything about that, but I think this conversation really raises kind of what you were asking earlier about what people can do. And I think the important thing to keep in mind is that there is no silver bullet when it comes to prescription drug prices. And this is an incredibly, Inflation Reduction Act is an incredibly important first step. But this fight is definitely not over. And AARP has been really clear, like we immediately pivoted to, we're not going to stop until medications are affordable for everyone. And that is our plan. So being mindful that, again, important first step, but this fight, I have job security. This fight will be going on for a long time. And so the other thing we have to be mindful of is that big pharma is incredibly innovative when it comes to
Yes.
finding ways to keep their prices high. And so we're going to have to be on the lookout for what they do next and have that fight as well. So
Yeah.
yes, everyone needs to stay engaged and stay on their toes, I think is the best way to describe our situation.
And I think that's a task for us as volunteers as well, to continue to remind people to talk about the challenges that you are facing, because there may be someone working on them, or there may be a solution that we can work on together. I wanted, Leigh, for you to go back a little bit and talk about the vaccines. Just expound on that a bit more.
Yeah, this was an interesting kind of artifact from the creation of Medicare Part D, where all commercially available vaccines that weren't covered under Medicare Part B as in boy, so like pneumonia and flu are covered under Medicare Part B. All of those other vaccines were covered under Medicare Part D. And it just wasn't structured in a way that made it easy for people to get those vaccines. The plans would cover them, but you might have different cost sharing depending on what plan you were in or whether you had met your deductible. And so we would hear specifically about shingles because it is a fairly expensive vaccine, where people would be asked to pay full price and then submit for reimbursement because doctors didn't know how to work with Medicare Part D. And so this eliminates that. Any vaccines that are recommended for adults will now be no cost sharing under Medicare Part D, which removes a huge barrier for people that were facing those costs.
Wow. Okay. That was a personal one. I thought I heard that. I wanted you to talk about it because I need to get the shingles shot, and I've just been like, I'm not ready to do that just yet.
You would be amazed how many people I've heard from who said they were putting it off. And then they hear about this change, which, by the way, starts next year. And they will be running to get their shingles shot as soon as the plan year starts.
Okay. All right. That's good.
Could you address that a little bit? You just you kind of touched on that. Things start next year, but then other things start other years, out there. So could you kind of lay out a timeline of what some of these changes mean for people?
Absolutely. And we actually have a great blog on .org if anyone's interested in reading them a little bit more about this themselves. But yes, this is something that is definitely building over time. So for example, at the end of this year, drug companies are going to start facing those penalties for big price increases. And by next year, all parts of Medicare will be involved in that penalty mechanism. Then free vaccines start in 2023. The insulin copay caps start in 2023. And then 2024, 2025 is when we really start getting interesting. In 2024, there's no more cost sharing once you reach catastrophic coverage under Medicare Part D. So there used to be 5% cost sharing once you hit that cap. And so we would hear about people having $10,000 to $15,000 in out-of-pocket costs because they were still spending in catastrophic. That won't happen anymore starting in 2024. The premium stabilization, which means premiums aren't going to increase any more than a certain percentage per year, goes between 2024 and 2029 and could actually extend even further, 2030 and beyond. There's expanded eligibility for Medicare Part D extra help, which is complicated, but basically it means more people will be able to get help with their premiums and their cost sharing, and that's also 2024. And then 2025 is the big year. That's when you look at, there's a big change in the Medicare Part D benefit, but the most important one for the vast majority of people in Medicare Part D is that $2,000 out-of-pocket cap, which is huge. It means no one is really going to face a year where they have thousands and thousands and thousands of dollars in out-of-pocket costs. They have that protection. And I always like to point out to people, you may not hit it this year, but you are one very expensive prescription away from hitting it. So this is a protection for everybody. And then in 2026 is when negotiation and negotiated prices kick in. We will start seeing those negotiated prices for those very high spend drugs. And that's when people will start seeing, and we actually will get the list of the drugs at the end of next year. So this is something
I was going to ask about that.
Yeah, this is a role. It's going to take some time to get this up and running. And we have to be honest, the country has never done anything at this scale before.
Okay.
But they're starting, it will start rolling out. We will have the list of drugs they're going to negotiate at the end of next year, and those prices will become available in 2026. And then more and more of them will start becoming available every year, and it's cumulative.
Okay. Yeah, that's good. That's good. Okay. So where are we? Do you see any additional questions, Therese?
Yeah, I mean, as we look at this, I mean, I'm really interested in what's going to happen then in the state of Ohio. I mean, we've got all these things going on around us that could really impact Ohioans right here. And I mean, like, other changes possibly to, like you were saying that, maybe some of the shots would be covered. And then the other thing is, we had the Governor's Prescription Drug Council, and they were supposed to, and I think they have done a lot of things to leverage spend in the state of Ohio. And if you knew anything else about what was happening with that, that council, if they're able to leverage some of the changes that are happening at the federal level to see if we can bring them home to the people in our state.
Were you asking a
Sorry.
question?
Yeah, I think
I don't have any more information, honestly, unfortunately.
Yeah.
Legislatively, I don't know that there are any major changes that I can see. Certainly, we're not back in session until the
A while.
end of November.
Yeah.
And then there's a pretty crazy period of time between the end of November and the beginning of December that everyone's heard the term lame duck for.
Yeah.
And I'd love to say that some of these bills can move forward then, but I don't know of any that are likely to. Certainly, I have the two that I will be pushing and advocating for. And certainly the federal changes, I think, again, bring that awareness. But
So I wanted to throw something out since why not? And I've tried to raise this with everyone I talk to. Going back to my saying that some of these provisions have a much broader impact than they appear. Medicare negotiation, those negotiated prices will become public. And so one thing I'm trying to help people consider is potentially going forward using those negotiated prices as the basis for their own negotiations. And I could certainly see some states being very interested in that information. It introduces some transparency that wasn't there before, but using that kind of as their own threshold for, okay, now we see Medicare's got this, we would like to have this. And so that's definitely one way negotiation can have a much broader impact, I think, than people are expecting.
Yeah, there is a question. Someone asked, will the donut disappear?
Oh, is that that gap you're talking about?
Yeah.
That will definitely disappear, because we have had so many stories around the state of Ohio where people, retire and they think they're doing okay on Medicare. They hit that donut,
Right,
and all of a sudden have to sell their home, to get through that donut. And what exactly does that mean right now? It's like a coverage gap where they have to do some.
So this gets complicated very quickly, but I will see what I can do. And please raise your hand if you have questions. Okay, so the original Medicare Part D benefit had that coverage gap where you're originally responsible for 100% of your prescription drug costs when you hit it. And then you would stay in that coverage gap until your out-of-pocket costs hit a certain threshold.
all right.
There have been changes since then that technically closed that gap. So people would only be responsible for 25% of their cost sharing from the time they hit their deductible until the time they hit catastrophic. But plans still treated the coverage gap differently. So you may have a flat copay when you're in that initial coverage period before you hit the coverage gap. And then you would change to 25% co-insurance where you're paying a percentage of the drug's price. So people would see really big increases in the amount that they were paying for their prescription drugs. So that coverage gap was still affecting people, even though it was technically closed. Under the benefit changes that are happening under the Inflation Reduction Act, that coverage gap will finally be gone. There will be no more wallpapering over it. It will actually be gone. So people will have hopefully much more consistent cost sharing from the time they meet their deductible until they hit that $2,000 out-of-pocket limit.
What year did that go into effect?
I'm sorry, the original coverage gap?
No, like the new change for people so they can see it coming.
Yes, that is in 2025 is when all of that benefit redesign happens.
Okay. Wow.
It's a big change for people. And that's another one of those things that I don't think people are aware of, but it's a big, important change because that coverage gap negatively affected millions of people.
Yeah, that's definitely something to advertise. And kind of like as we're going through this, like you always hear that we're after big pharma. And I hear people talking about PBMs and the fact that big pharma is a problem, but really they're not. It's the PBM that's a problem. And there was, I don't know if it was Dateline or one of the Sunday morning shows where two gentlemen were trying to discuss why this is so complicated that it isn't one or the other. I mean,
Yeah,
I get it that we need to go after big pharma. We need to reduce costs. Are we going after the right thing? Do we need to do more in other areas?
yeah, good question.
So I hear a lot about PBMs, which I find fascinating because they've been around for over 50 years and I'm only just now hearing about them. And part of that is the fact that we know that there's a very concerted effort to divert attention to them. Not saying they're angels, I'm just saying they've been targeted. And I think when it comes to prescription drug prices, the important thing to keep in mind is that since 2017, 47 states have passed over 125 bills related to PBMs. And when you look at what prescription drug prices are doing, just this year alone, we've already had almost 1,200 price increases. And there's really no indication that any of the drug price trends that we've seen have changed. So while I think there is definitely a role for PBM bills in the sense that they're correcting those problematic business practices, when it comes to drug prices, they don't seem to be doing a whole lot based on what we've seen so far. And AARP's position has consistently been that drug companies are the only entity in this chain who are able to set and raise prices. So any solutions are going to have to address that fact. And then we can get to fixing everything else.
Right.
Wow.
And is the system as complicated? I mean, I get it. It is big pharma. Then you start hearing about all these different middlemen. You know, is it important to understand that it isn't one person? Is it one person? You know what I mean? That is driving all this craziness.
Well, I think we do have to be mindful that, again, the drug companies are responsible for prices. Now, what's driving their pricing behavior could be entities within that very complicated system. And I wish I could share my screen because it's like a flow chart that takes up an entire page when you look at all the different parts that are in there. And there are definitely some misplaced incentives that could be playing a role in encouraging drug companies to increase those prices. But the reality is, as long as they are free to engage in those pricing behaviors, we are going to continue having problems regardless of what happens elsewhere in the supply chain.
Right. And what if we heard then, you know, if drugs are a problem, what if we heard about generic drugs and the ability for them to really step in, be made more readily available, and all these patents that continue to go on with the drug companies?
Yes, speaking
It's
of
a class.
an endless fight, that falls under that umbrella of indefensible behavior that we're seeing with the patents, or like pay for delay, or anything that's delaying the availability of those less expensive generics. The competition that we see within the generic market typically leads to price decreases. So that's why when you have a generic come on the market, you have a whole bunch of competitors and then the price goes down, and that's when we see those big savings. There have been some instances where generic drug companies have not behaved appropriately, and we've seen some big price increases, but overall that market is much different than what we see in the brand side. People are not complaining about the affordability of generic drugs.
Right.
That said, there is a lot happening in the system, patents. There's something called evergreening where they tweak a product and keep their exclusivity. There's patent thickets where they'll get hundreds of patents on a drug for things that don't really make that big of a difference. There's a lot of those shenanigans, as I call them, happening that can unfortunately extend the monopoly periods for those brand name drugs. And that's something else that's going to need to be addressed.
Yeah.
Yeah. So, I mean, is there any plan in the future to like start going after some of those patents, or, you know, really knocking those down to make some of these drugs affordable to, you know, we talked about the Medicare people and the people who have health insurance, but there are still people who need medications that are really left out there alone.
Yeah, absolutely. And that's kind of the reason that we need all of these different solutions, is to avoid that squeezing of the balloon where one part of the system can get those lower prices, but unfortunately other people who don't have that same protection are going to pay higher prices. There's been a lot of activity at the federal level. There are a lot of people in the Senate who are very interested in the patent problems, and they've been holding hearings and coming up with legislative text. So I would not be surprised to see a lot more work on that going forward.
Yeah.
What is a typical patent? How long does it last? Like 20, 30
20
years?
years. But what we're seeing is again, those kind of little tweaks. And then I'm not trying to throw anyone under the bus here, but there have been some questions about how patents are granted and whether they're being granted in circumstances where perhaps they should not be. And so there's been a lot of discussion about maybe trying to clamp down a little bit on when patents are awarded and making sure it's truly something that's bringing some value and some innovation.
Yeah, yes, I can see that. Well, as we start to wind down, I don't think we want to keep you longer than necessary. I do think, however,
there's another question, Ernestine. There's another question.
Okay.
And
Okay.
this one's interesting too. It says, we were led to believe that this was life-altering relief for us seniors. If I'm hearing correctly, nothing of any substance takes place until 2025, and some not until 2029.
Yeah.
He says, I'm not impressed. And I think I understand the frustration, but I think people also need to understand, like you were saying, the monumental task that we're undertaking in getting some of these things systemically through an entire country and some deep-seated institutions. Could you kind of speak to that?
Yeah, absolutely. And I would say, first of all, I mentioned that those penalties kick in at the end of this year, and that means that drug companies are officially on notice that they're going to be penalized if they increase their prices faster than inflation going forward. So those price increases hopefully will be discouraged pretty much immediately because they know this is coming. When it comes to negotiation, the Department of Health and Human Services is going to have to set up an entirely new office to administer this.
Yeah.
We just heard this week they're going to have 100 open positions. This is something that we have never done before in the United States, and getting the expertise that is needed and hiring, takes a while under normal circumstances, but they're expecting to have their list of drugs by September of next year. So this is something that's, at least for the government, moving fairly quickly. But the negotiation is also kind of putting drug companies on notice that they're going to have a higher level of scrutiny on their products than they did before. And this is something other countries have been doing for a very long time, but again, we're just getting it off the ground. So it's not like turning a light switch, unfortunately. This is something that's going to take time. And for example, the changes under Medicare Part D, the 2023 plan year is already baked. So there are only so many things you can do given how the plan year works and how quickly plans need to be able to accommodate those changes that are happening. So again, they've built in some time to do this, which I understand and appreciate fully is frustrating, but this is a big scale change in a number of different parts of the healthcare system.
Yeah, I understand the frustration as well, but look how long it's taken to just get to this point. And if things did not take so long, people were be more likely to get ready for them, but they're just like, this is going to go on forever. So I'm not going to worry about putting my ducks in order until I have to. Unfortunately, that impacts us. So again, I think as we start to wind down, we need to say to one another the things that we should continue to do, because as you said, the fight is really not over. And there will be a new fight. So we need to stay in tune and aware. So I encourage you, I invite you to give us some kind of final go get 'em. I'll start with you, Representative Liston.
Well, culture changes because people share their stories and keep talking about the things important. So I encourage everyone who's on here to, reach out to their state rep, their state senator. It's easy to find on, their actually legislature.ohio.gov. If you go there, you can put your address in there. It'll tell you who that person is, and share your story. Share why this is important to you, what it looks like in your life or the life of your family. You can do that through email relatively easily. You can give a phone call and speak with their office. If everyone keeps doing that, that issue stays at the top of people's minds. For specific bills, I know that the AARP tracks bills, and certainly they've been talking about 305. That bill, will be in a committee. That's in health committee. You can reach out to the health committee members. If you have a story, you can copy paste that email to the rest of the members to make that same phone call to all of those offices. state legislature is a little bit different than federal. Like we really do hear from people, if you're on a committee, you expect to hear from people that aren't your constituents about the bill. And, it affects everybody in the state. So it's, I think, reasonable. And it's not like a congressperson that might get hundreds and hundreds of calls. 5 calls, 10 calls, people notice if you're on for the same thing. So I think there's advocacy, just this group, even on this webinar can matter, and keep doing it, because it doesn't change quickly, as we've discussed. But if you call every month and talk about it again, it'll get noticed if there's a group of committed advocates. So, and I know that AARP is, so that would I'd say.
So Leigh?
Yeah, I would go back to really making sure that people appreciate that while this is an important and historic first step, there's a lot more to be done. And so staying engaged and elevating those voices of people who are really being impacted by high drug prices is incredibly important. And also, of course, patience. This does take some time for things to roll out, but the reality is I've been working on this for 17 years, and I can go back to the 1950s and find testimony where people in Congress were complaining about high prices. This is a big change that took a very long time to get here. So I think people will be very happy once they see the effects of this legislation once it becomes available. And I think the other thing important to keep in mind is that this really is kind of a sea change in a way. This is a new precedent for this country in the sense that we are no longer accepting prices that are based on what the market will bear. And that puts us on much more equal footing with countries who are paying significantly lower prices. So even if you're not thrilled with everything that's in there, the precedent that's being set and the warning that's being sent to drug companies that it's no longer business as usual is incredibly important. So please try to keep that in mind as well as you continue this fight. Again, it's incredibly important. There's still a lot of people that need help, but this is a really, really big first step.
Yes, I totally agree. Therese, it's all yours.
Yes, ma'am. Ernestine, before we go, what we really should do is, like, everybody who's on here, anybody who's worked on this, we'd like to thank all of you who've worked tirelessly to send letters and call your congressman or stood at the State House with us, as we've worked on this over the past 3 years to secure this really historic victory. It really is the fruit of all the advocacy that's gone on at home and then nationally. It has taken a long, long time. In fact, I think I've been hearing about this kind of like you, Leigh, like most of my life, and for something to finally have moved, it was like moving a mountain. Anybody who's worked on this, like your dedication benefited not only the millions of older Americans who struggle to afford their life-saving prescription drugs, but the 50 population as a whole. This really helped. And I want to thank everybody for participating in the conversation. And as we wrap up this event, we want to thank you all so much for joining this conversation. And thank you, Representative Dr. Liston, and Director Leigh Purvis, for taking time out of your busy schedules. You guys are so informative, and you really have great conversation together. Because you're both so knowledgeable at this. It's really appreciated.
Yeah, very much so. Very much so.
So thank you. Yes, thank you all for coming, and have a great evening. We're going to end the webinar.